Lobsang.
Good morning, Shubh Pravatam, respected chairperson, co-chairpersons, moderator, convener, co-conveners, panelists, esteemed ISOC members, and dear friends. So I'd be speaking on the basics of IPCL. So IPCL is basically a single-piece posterior chamber phakic IOL which can be inserted into the eye through a sub 2.8 mm incision. It has the widest power range starting from plus 15 to minus 30 with a cylinder up to 8 diopters. It is made from hybrid acrylic material to ensure long-term performances. And it's very easy to implant. It can be very easily replicated. And the learning curve also is, I think, very easy. And the patient also has a very fast recovery. And the surgery is less invasive as compared to LASIK and PRK. And the surgery is reversible. And in phakic IOLs, you have enhanced depth of vision because of the proximity to the nodal point of the eye. You have uncompromised contrast sensitivity, zero induced spherical aberration and coma, and you have ability to provide astigmatism remedy and also presbyopic correction. So preoperative assessment, what we need to do, we need to do a objective and subjective refraction. We have to measure the internal AC depth, that is from the endothelial side. If you are doing a conventional ultrasound, then you have to deduct pachymetry from that. And you have to get a good K reading and do a corneal topography. White to white measurement is very important to get a good vault. And white to white should be from the mid-limbus, and it should be done with a digital caliper or with a vernier caliper under high resolution magnification in the microscope. You have to do a IOP measurement preoperatively. If patient is having glaucoma, then I think this surgery is not very indicated. You have to get a detailed anterior and posterior segment examination and also do specular microscopy. So indication of phakic IOL is any person above 18 years of age you can do, and the refraction should be stable for 1 year. Patients who are not suitable for LASIK, if the cornea is very thin or having very flat or very steep K reading, then this surgery is indicated. And myopia, astigmatism, presbyopia, or any other ocular pathology. So this surgery is contraindicated in myopia other than axial myopia. And if the endothelial cell is less than 2,000 cubic millimeters, then this is contraindicated. If AC depth is less than 2.8, you shouldn't go for phakic IOLs. If there is a history of uveitis, if you have evidences of anterior or posterior synechia, you shouldn't go for phakic IOLs. Glaucoma or IOP higher than 20 mm of mercury, we shouldn't attempt phakic IOLs. And if the patient is having cataract, then always you go for cataract surgery. And diabetes is also contraindicated. So advantages of IPCL over LASIK and PRK is that in phakic IOLs, you don't touch a healthy cornea, whereas in LASIK and PRK, you remove a part of corneal tissue. That contributes to dry eye in cases of LASIK and PRK, whereas dry eye is not very common in IPCL. And this surgery is reversible. If there is any complication, then you can remove it, whereas LASIK and PRK are irreversible. And in cases of thin cornea also, you can go for phakic IOLs, and it gives good UV protection and asphericity. So complications, if you see, if you haven't gone for a adequate size, then there can be decentration. Pupillary block used to be there, very common. Now with the central hole technology, you don't get pupillary block glaucoma. There is pigment dispersion. There can be anterior subcapsular cataract and infection, post-op infection. So this is a surgery. I think video is not very clear, but then yeah, anyway. So we do paracentesis. And I do all the surgeries under hydroimplantation.
Hello.
So while loading the IPCL, it's very important to see for the orientation. The haptic hole should be on the left-hand side, and the Two superior holes should be on the superior side, covering which should be covered with the eyelid. And under hydroimplantation, I am implanting the IOL slowly, phakic IOL slowly. Then you dial the haptic under the iris, and the receding like the haptic. Also, you place it under the iris, and you see for the orientation. Orientation of the IPCL is very, very important. The two superior holes should be on the superior side. I am not using any visco. This is done totally under hydroimplantation. So after getting a good orientation of the IPCL, then you inject pilocarpine, and then whatever little bit of visco, because I put visco in the cartridge, so a little bit of visco you remove, and then you do the stromal hydration, and that's the end of the surgery. So the success of IPCL surgery is that you should have a very, very good patient selection. Your measurements should be accurate. You should do good patient counseling, and your surgical technique should be good. Post-operative observations should also be very, very careful. And with experience, I think this surgery is a very good tool in your cataract and refractive surgery basket. Thank you so much.
Comment from the panelist.
We can put the presentation as phakic IOL instead of this is a very company specific name. I think this we may avoid in future.
Okay, right. So just one quick question. Lot of centers, I mean, lot of cities do not have a specular microscope. So can those people go ahead even without doing any alternative measures so that slit lamp good examination? Can we go ahead with that? No, is it absolute?
But learning curve, I think as per the surgery, if you see, it's very easy to perform.
So what is the exact clock hour when you have to put those holes?
No, holes basically the orientation of the like phakic IOL should be proper. The preceding haptic, there is a hole. It should be on the left hand side, and there are two superior holes. So that should be on the superior side while you orient the IOL, phakic IOL.
Dr. Lobsang.
This is a very good presentation actually. He has put it in the without visco. That is a very tricky and it's a very risky affair actually. What we are doing with visco.
Yeah.
Visco is a good because you will get more space. And what he has not mentioned actually, he has shown in the video. The second instrument should guide the lens when it is going in, because the lens might
Rotate.
Yeah, rotate. Yeah, there are chances of rotation because
So you have to flip again. So flipping is another problem.
No, flipping should not be done inside. You have to take out the lens and then only insert it again. You cannot flip the lens inside.
And second instrument should be guided.
Lobsang, at the end of the surgery, instead of hydrating the wound, will it be more safer to if you stitch the wound?
No.
no.
No, sir.
It's a very small
stitching
incision, so
No,
I don't think so.
but
You
we
need
should
to-
be sure there is no leakage.
Yeah,
no?
that is true. That is true.
So our suggestion leave a little bit of bubble of air. Sometimes the AC leaks, then the lens will not touch your cornea. Just leave a little bit of air. That will take care.
Thank you.
That is answer.
Sir?
As such, we are putting the lens over the.
Yeah, 2.8.
2.8.
Yeah.
And in the very next day, one day after the surgery, you should see the IOD applied.
Yeah, IOP is very important.
And also
to
the vault,
check.
the vault also has to be seen
Vault
on
also
day
has
one
to be
also.
checked in anti-segment OCT. Yeah. Thank you.
And most of these cases have some amount of astigmatism also. The high marker, they have -1.5.
And,
Thank you.
and Dr. Lobsang, is it necessary to put pilocarpine at the end of the surgery intracameral?
It's not mandatory, but then to get
You
around
put it.
people.
Okay,
and,
right,
yeah.
right. Okay, right.